Our next and final speaker for today is Dr. Dan Parker. Dan is a research fellow and lecturer in digital health at the University of Salford, and today Dan will be discussing a digital approach to orthotic design and production for the at-risk foot.
Thank you for that introduction, Jen. So I'm going to be taking on a little bit more of looking at how we build a product digitally and then how we put that into service. And leading off of a couple of the talks that we've heard in the earlier session, really, involving how we might monitor or capture some of that data. But just to broaden that context around the diabetic foot, we've got a growing problem in terms of the prevalence of diabetes and the impact of diabetes on people's feet conditions and their general health anyway. And really the key in this is that there are about 80% of foot ulcer related lower limb amputations are preventable. And that can be either through the strategies that we've heard from Simba and from Neil, looking at how to monitor or manage that in a patient-facing way, or through providing them better products and products that manage their foot conditions much more effectively as well. So really trying to tackle that from a couple of different ways. Now, in terms of the products and the foot orthotics that we provide for patients who have diabetes, there are a couple of guidelines, a couple of recommendations. And the International Working Group on the Diabetic Foot have developed a guidance specifically for patients who've previously ulcerated and who are at greater or greatest risk of re-ulceration. And the targets there are to reduce pressures under the foot to below 200 kPa, or at least a 30% reduction from their starting position. That should be the target for any clinician in a pressure perspective. And now, going down the scale into a more moderate or a lower risk foot, the requirements may be less burdensome, but taking that as a starting point is a good benchmark when we're looking at effectiveness in orthotics. So to assess the effectiveness of a digital approach to orthotic design, we developed a randomized controlled trial in which we recruited 57 patients who had moderate risk diabetes. And by moderate risk, we mean that they had some reduced vascular supply, some peripheral neuropathy, and or signs of callus or change to the structure of the plantar tissue that may predispose them to damage. We provided all of these patients with custom-made orthotics, and they entered a 6-month wear trial. They were randomized to 2 arms, so half of the cohort received a traditional approach, which is where they would have an impression box taken in clinic, and that would be sent with a prescription to a orthotics lab who would produce a molded EVA orthotic. Or the other half went into a digital design arm. So they received a foot scan, and then they integrated that foot scan with some initial plantar pressure data, just standing pressure data, into a CAD system to allow for a digital design of an insole, which could then be milled. In the case of this randomized control trial, it allowed us to mill those and produce them in EVA. So we were using an equivalent material to those used in the traditional supply chain. We then focused on the forefoot region because that was the primary region for the patients who were being recruited into the trial. And we broke the plantar pressure data down into 5 distinct regions within the forefoot. We looked at within each region to identify what we considered regions of interest. So that's where the pressure was greater than 200 kPa at baseline. So before we've given them an insole, do we have high pressures or what the International Working Group of Diabetic Foot considers at-risk pressures? So in some participants there was 1 region, and in some participants there were more than 1 region. So in this example here, you can see that there's 2 regions that have gone over the 200 kPa, and these were considered independently. So then looking at the effect of these 2 different supply chains, we identified that both digital and traditional supply chains were provide significant reductions in plantar pressure compared to the control or the baseline condition. And then looking at this across the duration of the trial, we can see that across the cohort, we can see that for some individuals in the traditional group, we saw reductions in pressure, but for some we saw increases in pressure. Again, we see a similar pattern in the digital supply chain group, but more consistent in terms of reduction of pressure. So we're able to have because we're using some of the plantar pressure data into the design, we've got a more targeted intervention, and we're able to provide a more effective solution for more patients. However, there weren't any across the cohort. There weren't any significant differences, or there wasn't a significant improvement in pressure reduction with the digital supply chain arm. We were able to demonstrate equivalence between the two cohorts, but we didn't identify any changes in health economic outcomes, so patient capability or patient benefit of quality of life over that duration. So we weren't seeing any changes purely from the orthotic intervention on the patient's lives effectively. And there was a difference in cost, but it was fairly minimal. So we were looking at about £86 for the digital orthotics and £73 for the traditional, and that included factors like the time for design and the production of material costs as well. But the time did prove to be a considerable barrier for implementation, so there was quite a burden on the clinician time and on any technician time to introduce that digital design approach. So in essence, this is just really not good enough. The digital design can provide some benefits, but it's just not doing enough for a patient to outweigh the costs of introducing those extra processes and that extra time. There are some longer term benefits that we didn't consider within this trial, and these include the option to integrate multiple materials, look at using different manufacturing approaches, and to do more complex aspects with material structures and design approaches. But perhaps the most important aspect of a digital design approach is that you can have an iterative design, and more recent research has built on this, particularly Telfer's work, looking at how you can optimize design through iterations, building on the original design. With the traditional processes, it's very difficult to achieve because you're working with plaster, you're working with a product, and then you can't really go back to the design to make a distinct modification. With a digital process, you've got a design history, and you can make individual modifications as you go, which really allows you to make sure that when you give something to a patient, you're giving them the best option for them at that point. So to build on this a little bit more, we looked at how we can stretch that manufacturing approach, and we developed a randomized crossover trial which recruited 25 participants to look at 6 interventions of different design aspects and modifying those designs in that sort of upper version that I suggested before. We used a multi-material additive manufactured insole, which had a rigid outer and a more flexible inner. But in this case, because of the material limitations at the time, we had a rigid outer which was around about 70 Shaw, which is considered very high density, and then a more flexible part which was around 50 Shaw, so still moderate to high density. So we weren't getting a lot of flexibility within the insole, but we did have some scope for modification. To increase this modification, we introduced a volume reduction into the design. So we removed sections of the insole to remove cost, to remove material costs, and also to remove some of the weight from the insole to increase some of the flexibility as well. And we looked at a very different design, which used a full length but a very thin shell, so a 2mm shell, including a rigid and a flexible core that used the same. So in all cases, we were using the same rear foot shape that was developed from the scan, and just applying different modifications to this. In this case, we looked at 3 regions of pressure interest across the insoles, And looking at the forefoot region, we can see that the additive manufactured sort of core design was effective at reduction of pressure compared to the control conditions, the flat pour-on conditions, and some degree showed a reduction of pressure from the pour-on 6mm as well, but there weren't any differences between this and a traditional molded orthotic. Looking at these conditions in more detail, so just to pick up on that, we didn't see any improvements with the more advanced design approaches that we were using. So removing the material or using this shell type approach actually had a negative impact on the pressure that was seen in the forefoot, which suggests that these, although they're technically advantageous in terms of reducing material or reducing weight, they're not having any benefit for the patients. So just to focus on the additive aspect, we did see some limitations within this. So although we were reducing pressure, we see an increase in pressure in some of the other regions. So we see an increase in pressure in the midfoot, which is expected because we're introducing an intervention there. But we also see an unacceptable level of increase of pressure in the heel, pushing us from at around the 200 kPa marker, much more above that 200 kPa marker. So this is just not something that we want to see within that design, and again suggests a limitation within that material, those material options at the time. So just to build on this, we have identified a need to apply appropriate modifications to design with an optimized approach. And I think there is at the moment, there is still a large gap between the technology that's available and the treatment options, especially for moderate to high risk individuals. We have a bit more scope, and we're able to take more risks, or we're able to do more within a lower risk cohort. But at this level, we need to be very careful and cautious with the interventions that we choose, and we need to ensure that there's evidence that those interventions are going to be effective before we can implement them. There are many advantages and advances in the materials and the tools since this work was done, and certainly there's more flexible material and more flexible production options now, which may allow for more scope in terms of the products that can be produced and the options for this cohort. And as we've looked at, there's some of the processes are very time consuming. So we're using huge amounts of time to design and to integrate different options and different pieces of data. A lot of this is in the process of being automated and can be improved, which will have a huge impact on the supply chain process. But we have to have a better understanding of the best outcomes and the way to achieve those outcomes before we can optimize and automate some of those steps. So it really is going to go hand in hand. And I think as we saw from Neil Reeves' talk in the beginning of this session, there's a lot of external data and the capacity to monitor risk and monitor pressures within the foot that will be really useful for this optimization approach as well, and for understanding if we give someone a product, how well does it perform? How well does it perform in different activities and over a duration of time? Building that information into this approach and into this design approach will mean that we develop a product that isn't just going to work when we see them in the clinic, it's going to work throughout their use. But more importantly, perhaps we need to ensure that we're addressing the actual needs of the patients and the outcomes for the patients. At the moment, this work is still very much about how do we improve pressure reduction, but not how do we enable patients to become more active or to engage in the things that they want to do more. So it's how do we address that, or is there a capability within the design that allows us to enable patients to do that as well. Thank you for listening today. I'd just like to acknowledge a few of the partners from within Salford and externally who were involved in this project and some of the other work. We were funded by the EPSRC Innovate UK and had industry partners with FDM Digital Solutions, who conduct a lot of additive manufacture based in the northwest of England, and the East Lancashire NHS Trust.
Thank you very much, Dan. This obviously has a lot of promise in terms of reducing pressure under a patient's feet, but how do you see this being implemented in clinical practice? Because as you say, I've worked in the NHS before during placements, and they still do use very traditional orthoses manufacturing methods. How do you see this being placed into the NHS setting?
Yeah, well, I think one thing to consider is that a lot of insoles that are prescribed or sent out to orthotics labs are now being produced digitally. So we've shifted from a traditional approach to a mass manufacture digital approach, just because there's a lot of optimization in a lab setting. If you're getting 30, 40 insoles being sent to your lab every day for production, you don't want to be doing that all by hand. And if you can produce an equivalent device, or a equivalent just in terms of the materials and the product device, then you would switch to a more manufactured approach. So we are seeing that transition happen at that level, but unfortunately the inputs that are being used to do that design are still the same. So clinicians are still completing a prescription form and just sending it to a lab, and then they're almost oblivious to how it's being produced or what's being done. They're seeing the product coming back and they're making a decision on whether the product's of a high enough quality at that point. But there's not enough integration of their clinical expertise into that design approach. And I think that would be the best way. There's no benefit, certainly in terms of the data that we collected. There's a lot of cost and a lot of time associated with a clinician doing all of the aspects of the CAD design, but there is a benefit in including them more in that design approach, and maybe trying to find strategies to do that.
Yeah, that's really interesting. Just in terms of during a patient fitting, for example, when you're fitting an orthosis to a patient, sometimes we have to make certain modifications in order to avoid pressure points. Is there any potential to do that within these kinds of devices?
Yeah, certainly. The CAD systems allow for quite a lot of flexibility in terms of the design. There's the CAD systems are specifically designed for insole production, so they have already predefined additions or modifications that you'd make to an orthotic, like cutouts or recesses or those sorts of features. So certainly there's a lot of options around design within a digital system, and this again speaks to that sort of need of having some clinical input, because if you've got that huge suite of capability, but there's no use in that capability if it can't be applied to the in the right way or in the most effective way.
Thank you very much, Dan.